Hello everyone. So in this video we're going to talk about oncological emergencies, and specifically we will be covering the abnormal structures that actually occur with regard to the disease process or maybe in response to cancer treatment modality, and we will be able to further discern or understand as to why a specific structural abnormality is considered to be an emergency with regard to our discussion about structural oncological emergency. So let us proceed with the first structural abnormality that we can have, and that is the first one that the clients with cancer can have. And that will be in line with the first one, and that is superior vena cava syndrome. Superior vena cava syndrome simply referring to the presence of a tumor that is somewhat adjacent in the superior vena cava. And upon enlargement of the tumor, however, what could be the problem is there is now a compression of the superior vena cava. So let's talk about, or let's have an understanding as to what superior vena cava is. It is said that we have the inferior vena cava, the blood vessel, that actually receives venous blood from the systemic circulation, going towards back to the heart. And so we have this so-called venous return. Now, you have to understand that we also have this inferior or superior vena cava. The superior vena cava this time is capable of receiving venous blood also, but from the superior aspect of the body, from the head, from the neck. And so this venous blood will have to drain into the superior vena cava, finally going to the vena cava and then to the right atrium, to the right ventricle, and then eventually going towards the lungs for oxygenation, and then left atrium, left ventricle towards the systemic circulation again. After the systemic circulation, the venous blood will have to go back now because it is deoxygenated. It will have to go back to the inferior or superior vena cava depending on the location, where the upper half will be for the superior vena cava, lower half will be the inferior vena cava. So the point in there is that the superior vena cava receives blood from the systemic circulation on the upper portion of the body, such as the head and of that of the neck. If there is compression, if there is obstruction in that area, what do you think now will be expected? The expected manifestation now will be somehow impaired venous draining of blood into the right atrium, into the vena cava, because of the compression of the superior vena cava. So what do you think now will happen? Tendency, there will be a backflow of blood, or there will be a buildup of an increase in pressure in the systemic portion, such as the head, such as that of the neck. So that will be for superior vena cava syndrome. An increase in pressure in the head area or in the neck area can actually cause now tracheal edema, can actually cause now an increase in movement of fluid from the blood vessel into the cell, causing cerebral edema. So that will be somehow considered to be enough for us to understand that it is indeed an emergency situation. So basically, superior vena cava syndrome is characterized by the impaired drainage from the veins connected to the superior vena cava, such as the head and that of the neck veins. We proceed with the next one, and that would be the risk factors. What could be the reasons behind superior vena cava syndrome? It may be related to a tumor adjacent to the area, such as tumor adjacent to that organ. To the tumor of a particular organ adjacent to the superior vena cava, such as the lungs, such as lymphoma. So basically, this tumor are such as metastasis. So basically, if there is like mediastinal tumor, this can actually cause now obstruction or compression of the superior vena cava. It does not necessarily mean that the tumor is inside the superior vena cava. It could be outside, but due to the external pressure that this tumor exerts on the superior vena cava, there is now a reduction in the blood flow through that area, secondary to compression. Or it may be related to a tumor in a central venous catheter in such a way that the tumor itself, of course, can obstruct blood flow to the superior vena cava, much more if the tumor is so large that it can compress other areas too. So regardless of the cause, you just have to understand in here that there is a significant reduction of blood flow or allowance of blood flow to that area, causing superior vena cava syndrome. Manifestations now, based on your observation, now will have to, or will make you appreciate somehow the manifestations, because as you can see now, there will be edema of the face, arm, and that of the neck, suggesting that the upper half of the body have impaired venous drainage towards to the superior vena cava. Similarly, the client may have distended jugular, temporal, and arm veins, suggesting then again that there will be now a problem with venous draining of blood, and so the client may have to develop edema, tracheal edema, dyspnea, cyanosis, altered LOC, suggesting now that there is a decrease in oxygenation, or more so ventilation, leading to decreased perfusion and oxygenation of the cells. Cerebral edema. Because of an increase in pressure, the movement of water now will occur from the blood vessel into the interstitial space, causing now cerebral edema or anoxia, characterized by increase in ICP, altered LOC, neurologic deficits. You have to understand that the most sensitive indicator of neurologic change in this case will always be alteration in conscious level, and so GCS monitoring is also important. Now, diagnostic procedure may be in the form of chest X-ray in order to evaluate the presence of a tumor that compresses the superior vena cava, CT or MRI in order to outline the growth, and at the same time the size, to outline the size of the tumor that compresses the superior vena cava. Our management will be in line with oxygenation because tracheal edema is somehow an emergency situation. So oxygen tracheostomy may be indicated in order to somehow artificially provide oxygen, because the brain cells eventually will go into anoxia and then there will be now stroke. Corticosteroids, diuretics may be given. Why diuretics are given? In order to somehow relieve the area from swelling. Corticosteroids, because they are believed to be anti-inflammatory, preventing somehow cerebral or managing cerebral edema. Thrombolytics or anticoagulants may be given because one of the risk factors may be in line with thrombus that has formed in the central venous catheter. Chemotherapy and radiation may be ordered in such a way that we would like to somehow cause lysis or destruction of the tumor cells that compresses the superior vena cava. Surgery will be in the form of vena cava bypass graft. It is like connecting or correcting or providing an alternate route for blood flow into the superior vena cava in the presence of the tumor that compresses that specific portion. Another will be management in line with monitoring of cardiopulmonary, neurologic, and fluid status. Because of the presence of edema, fluid status monitoring is indicated. Cardiopulmonary, because somehow a decrease in cardiac output can be seen because of a decrease in venous return, right? So venous return, if decreased, can somehow decrease the blood pressure, can somehow decrease the blood volume. Although we know very well that the blood volume is only reduced in the left ventricular contraction simply because of a decrease in venous return owing to compression of the superior vena cava. Semi-Fowler's positioning in order to somehow improve oxygenation. Adequate rest periods, because we don't want the client consuming too much energy knowing the fact that oxygen is very limited in this situation. Seizure precaution owing to the fact that the client may be at risk to develop cerebral edema. Another will be in line with cardiac tamponade. Cardiac tamponade is characterized by an excessive accumulation of pericardial fluid. We know very well that there is a significant little amount only of fluid in the pericardial membrane. The pericardial membrane basically has parietal and visceral, and in between that is what we call the pericardial space. And the space basically has a few amount of fluid in it. However, in pericardial effusion, or an emergency form in such a way that we have the so-called cardiac tamponade, excessive fluid in the pericardial space can somehow limit the movement of the heart, right? And before I forget to mention, pericardial membrane is the one, or the pericardium is actually the one that encases or covers the heart. So, if in this case now, there is excessive accumulation of fluid in the pericardial space, the heart muscle may not be able to pump effectively. And so it is considered to be an emergency situation because the client may develop into shock. So the client may have cardiac tamponade and it is an emergency situation, and basically the management will be geared towards relieving the heart from this excessive fluid or relieving that pericardial space by inserting a needle towards that space, evacuating the excessive fluid, so somehow relieving the pressure, somehow preventing shock from occurring. Well, anyway, that is our introduction for that. The risk of cardiac tamponade is a medical emergency due to the accumulation of excessive pericardial fluid that gravely restricts myocardial contraction. The risk factors may be in line with cancer of the lungs, esophagus, and breast, owing to the proximity of these cancer organs to the pericardium or that of the heart. Radiation therapy is believed to be a risk factor. Why? It is because radiation is able to penetrate through and that the cells or of the membrane can actually be involved, brought about by radiation, and so irritation of those tissues surrounding the heart can actually induce inflammatory response. And so movement of water now will be from the blood vessel into the interstitial space, and so we have the so-called pericardial space. Not only that, the cells the capillaries will increase the so-called capillary permeability, meaning the movement of fluid will be evidently seen from the intravascular space going to the interstitial or third space called the pericardial space. Manifestation may be in the form of cosmal sign. Cosmal sign is characterized by, or it is going to be positive once, as the patient inhales, there will be now distension of jugular veins, owing to the fact that there is a problem with myocardial contraction, brought about by cardiac tamponade. Another will be pulsus paradoxus. This is characterized by a drop in systolic blood pressure of 10 millimeters mercury, or the disappearance of the radial pulse during inspiration, owing to a problem now with the vascular system because of the problem with myocardial contraction. Another thing will be muffled heart sounds. It is very difficult to appreciate or to hear the heart sounds owing to a reduction in myocardial contraction or restricted myocardial contraction because of the excessive fluid that surrounds the heart. And at the same time, it is very difficult to hear at a particular sound knowing that there is an increase in the fluid that somehow prevents reception of the sound. And signs of cardiogenic shock, evidenced by hypotension, tachycardia, tachypnea, cyanosis, and altered level of consciousness. CVP monitoring will be helpful somehow in order to evaluate as to whether CVP is within normal range or not. ECG will be determined or will be ordered in order to somehow determine whether myocardial contraction is still within normal range, whether we would like to determine if there is still NSR or normal sinus rhythm. CT will be helpful in order to evaluate heart structures, blood vessel structure, specifically in line with that of cardiac tamponade. And chest X-ray is somewhat significant. It is very, very common in here that chest X-ray will be ordered in the presence of cardiac tamponade. Why? Because it will outline or it will show bottled water shaped heart. So basically, it is like a bottled water simply because of the idea that the heart is actually surrounded by excessive amount of fluid or water. So in line with the management for cardiac tamponade, you have to remember that oxygen still becomes our priority owing to the fact that the myocardial contraction is not sufficient in order to meet the demands of the cells. So oxygen therapy will be indicated in this situation. Now, vasopressors may be administered in order to somehow strengthen the vasomotor tone because, as we mentioned earlier, there is somehow an involvement of the vascular system. Pericardiocentesis sclerotherapy may be indicated in order to somehow relieve the pericardial space from this excessive fluid. And so basically the physician will have to insert a needle with a syringe in order to aspirate the excessive pericardial fluid, which is actually considered to be the emergency procedure or the emergency medical procedure that must be performed right away in the event that the client goes into cardiac tamponade, because we don't want the client developing into cardiogenic shock. Sclerotherapy may be indicated because it would like to promote sclerosis of the tissues in order to prevent somehow movement of the fluid towards the pericardial membrane. Radiation and chemotherapy will be helpful in order to somehow remove the area, or somehow radiation chemotherapy in order to somehow remove the tissues that can cause promotion of movement of water into the pericardial space, since we've known very well that cancer involving these organs adjacent to the heart can actually cause now pericardial effusion, or more so this emergency condition called cardiac tamponade. Vital signs monitoring and oxygen saturation will be indicated knowing the fact that there is involvement of the vascular system, affecting myocardial contraction, and that oxygenation is greatly impaired in cardiac tamponade. Elevation of head in order to somehow promote maximal lung expansion. Adequate rest periods because of the increased oxygen demand brought about by physical activities, and so it is important that the client will have to be restricted in terms of activities, and so the client should be placed on bed rest. Coughing and deep breathing exercises can somehow promote maximal lung expansion, improving oxygenation of the cells. The last structural oncological emergency will be in line with spinal cord compression. It is said that the tumor is able to cause compression of the spinal cord, more so if the cancer has progressed into other parts of the body, such as the spinal column. So in this case, the risk factors associated with spinal cord compression may include cancer of the breast, especially if it has metastasized, lungs, prostate, or of the bone itself involving the vertebrae, lymphoma, and metastatic disease. Now, with the manifestations, since the spinal cord somehow is in line with the function or at the same time transit of the spinal nerves, the one responsible for sensation or as a form of communication towards the brain's reception of any sensation, somehow we can say that a compression of the spinal cord can somehow affect all alter sensation. And so early signs would include progressive back and leg pain, numbness, paresthesia, and coldness. Late signs, however, will include paralysis, which can somehow be more severe as compared with the late signs, weakness, paralysis, bowel and bladder dysfunction, owing to the fact that there are some spinal nerves responsible with innervation at the same time function of the bladder. So the problem now is that the client may be incontinent or may have dysfunction with the bladder. There may be bladder incontinence, or the client may not be able to feel that the bladder is already full. So basically, catheterization is one of the expected management for this. MRI, CT, spinal cord X-ray, and bone scan are helpful in determining the presence somehow of metastasis or whether or not the tumor has formed in that site as a primary site, or in order to determine basically the extent of the disease. Now, the management basically of spinal cord compression will be in line with corticosteroids. Corticosteroids in order to relieve swelling of the spinal cord. Analgesics because of the pain that the client experiences. Radiation and chemotherapy in order to address the problem with the tumor that compresses the spinal cord. Surgery will be in line with surgical decompression in order to relieve the pressure that exerts effect on the spinal cord that gives rise to the manifestations. Assessment of neurologic function, whether or not the client is able to feel sensations such as sharp or dull sensation by introduction of a needle or by that of the edge or the end of the hammer or any assessment instrument tool. Now, another will be preventing complications related to immobility, because it is said that if the client develops paralysis, the client may be immobile, and so it is but important that we will have to be careful with regard to bed sore formation or pressure sores or development of hypostatic pneumonia. Or the client may be at risk to develop also deep vein thrombosis in this case. So it is important that the client should perform range of motion exercise. Now, if the client is not able to do that, maybe in the form of passive range of motion, or if the client can perform or help active assistive range of motion exercise. And finally, with regard to bladder or urinary catheterization because of bladder dysfunction, or bowel training because the client may also have bowel incontinence. So that ends our discussion of structural oncological emergency. Thank you for listening. See you on the next videos prepared for you, or have a review on the videos you've seen before with regard to oncology nursing and specific cancer types. Thank you very much for listening.